Welcome to the Poisoning Podcast. I'm your host, Erin DeLullo. I ask that you rate, review, and share this episode with a friend. Today, I have Dr. Kristin Martin of River Valley Medical Wellness joining us. Dr. Martin is an accomplished osteopathic physician with extensive experience in emergency medicine, family medicine, and addiction medicine. She is president of the Arkansas Addiction Medicine Council and is a board member of the Federation of State Medical Boards, Opioid and Addiction. So welcome to the show, Dr. Martin.
Thank you. Thank you so much, Erin.
We first started talking maybe 2 weeks ago on a Saturday. I love that you call me on a Saturday. I'm always working. And I just was so captured by your energy and all the work you're doing. And so I'm so excited to have you here. I would like, one of the things you told me that day in our maybe 40-minute conversation was how you got started in addiction medicine.
Absolutely. So for me, getting started in addiction medicine really was what I witnessed while I was working as an emergency room physician. During COVID, of course, everybody was, healthcare providers were working extensively, and I was a ER medical director for an emergency room, and then was working for the first 18 months of COVID. I worked a different ER in our state every day. So not only was in one main location, but then lots of the other areas, making sure that we had coverage. And what we started to notice was that I saw more cases of opioid overdose and more cases of mental health crisis than I did actual cases of COVID for that first 18 months. And I just was astonished. What we were expecting to see and deal with was something totally different. And it was so difficult to call family after family and tell them that their loved one had passed, that they had died from something that we considered preventable. And I think I shared with you, what at that point in time as ER providers, we wore a badge of honor of being the front line of what was going on. And the communities were so conscious, they bring us dinners and things like that. And we all sat around and we really sad about what was going on, not just with the COVID crisis, but looking and saying, listen, we are missing the boat as a country. There is a whole nother epidemic going on out here that no one is talking about, that no one is recognizing. And so at that point in time, we decided as an ER team that by the time people got to us, the crisis had already occurred. Where we could have intervened, usually in a more fruitful way, had already occurred. And so we got tired of being at the reaction end of that, and really wanted to step out into our communities. And I told the team, I was like, we said we're frontline providers, but really we're not on the front line of the opioid epidemic if we're sitting in the emergency room. So we decided to step out and step up into our communities to try to get Naloxone out there, provide evidence-based care for people, and really start opening up the conversation, which there was so much stigma about, and say, hey, we've got a problem. And we want to help solve that problem before it gets to the emergency room, before we lose another 19-year-old to a fentanyl overdose. Let's do something about it. So that's actually how we started in this space, really. And we were doing some physicals for some of the treatment centers and things like that. But really, it was what we learned and what we thought we were going to learn were two absolutely different things. So
River Valley Medical started when?
So we started in June of 2020.
Oh, wow.
And we literally set up a clinic in a week's time. There were several of the treatment facilities or outpatient programs that were helping people with opioid use disorder that closed. overnight. There was several of those facilities that closed due to COVID, other ones that had funding issues, where resources were shuttled other directions. And so um, literally overnight, there were some facilities that shut down that were serving like 300 patients that were receiving Suboxone or getting therapy, getting outpatient care, um, that these people had nowhere to go. There were not a lot of providers who were working in this space. And to be honest, a lot of the medical community said they didn't want to work in that space due to their sometimes their stigma and their preconceived notions. And I think a focus on COVID and things like that also, that they were all just trying to figure out how to keep their practices going. That um, whenever you're dealing with people with substance use disorders, the best care is one where you get to actually have some physical contact, where you actually get to have
Sure.
personal relationships with people, and can give them naloxone, can help provide them the care that surrounds all that. So yes, we set it up in a week, and we started um, really without a great deal of understanding of all the things we needed to do,
Right.
but we were willing to get out there and learn with our patients. Call somebody that knows the answers and say, "Hey, help us." And I think that's the thing too often we don't do, is that as medical providers, sometimes we don't always admit when we don't know. And we looked at it and said, like, not knowing is not an answer. We've got to get out there and start the work. So yeah, little did we know, and we started that just as a part-time thing to reach a few people that were in crisis. Now here we are, 4 years later, and have grown significantly and love every minute of what we do.
And how many people do you serve today on average?
Um, Several thousand in the
Yeah.
state of Arkansas.
Wow. In 2 years.
Yeah, and so we have now we have two clinics that have an integrated healthcare program that has primary care, mental health, and addiction medicine. And an important part of that is our peer recovery support specialists that we offer through grant funding for free for anybody, even if they're not our patient. We offer those services for free. And so we have two clinics, and then we now also have two mobile healthcare units that we've received through grant funding to be able to help go serve the rural and underserved areas of our state. And it has really taken off.
The mobile units are fascinating to me. When we were together about 10 days ago, um, the Attorney General of Arkansas mentioned to this group you were addressing, one of the reasons he gave you a grant is how reasonably priced a mobile medical unit is compared to bricks and mortar, and you can reach more people.
Correct.
The people who
Um,
don't have transportation, the people who are down, may not have the funds or some way to get medical, to a medical facility.
yes, and we absolutely in rural states, and I'm just going to be honest, most of our country has rural portions to it.
Oh,
The access to specialty services, whether they are cardiology or whether they're addiction medicine or mental health, when you're in a city environment, those specialty services are a stone's throw away. There's, you know,
yeah. You
can
can
be a
walk
hundred.
if you needed to. You could walk in a city. Yeah, right.
Yes, you can, or you could take public
Yeah.
transportation to go and get there. But when you're talking about rural environments, and we've done some research, we know that specialty services, like addiction medicine, are over 40 miles away for people living in a rural environment. And that's just one way. And so, I use the example of, especially in our current climate, um, that whenever you need those services, um, and with gas prices or owning your own car or being able to take time off of work to travel 40 miles away, have a 30-minute or hour-long appointment, and then drive 40 miles back. People who are working class citizens can't afford to take that time off of work. Or if you are a single parent and your choice is, I'm trying to feed my family, or I'm going to go make this appointment for this medication and this therapy and counseling that I need. Time and time again, a mother's going to pick feeding her child over
course.
sometimes getting the care that they need. Um, and so with the mobile units, we figured that out early on in our process because of the limitations those initial patients had in reaching us. And we were literally driving our own SUVs up and down the highway. Uh, and so I would see people and they'd say, "You're that little doctor that drives up and down the highway." And I'm like, "Yeah." And so we were meeting people at McDonald's, at a Starbucks, in their communities, and thought we should really have a more formal process for this. And a lot of people thought, well, it's not going to be advantageous in a rural environment. You have to drive too many miles. But I think when you actually listen to your communities, um, there are so many people that want help. They just didn't know how to access it. So taking the rural model or taking the mobile unit model out there, we have integrated, as I say, we have primary care, we have mental health, we have peer recovery, we have a little lab space that's involved. We hand out naloxone everywhere we go. And for a lot of the rural environments where those conversations have been taboo,
Mhm.
stigmatized, people fearful, or just they want help, but have not had the resources. Um, it's not fair that if you want help and you're trying to change your life and support your family and be successful in getting care for your uh,
Mhm.
condition, um, that you not be able to get that because of the zip code you live in. And so what we found is that there are definitely communities and pockets who are very much accessing this. And in other environments, we are having those conversations um, and being invited in by churches, by food banks, uh, local judges. I'm so
You,
sorry.
that's all right. No problem. So you've saved people with naloxone, correct?
Absolutely.
Can you tell us a few of those stories?
Oh gosh. So I think one of the stories whenever I decided that the first community we decided to take the mobile unit to
Mhm.
was a community where an ER physician at. Um, and there was a young lady who was literally dropped off at the back door of the
Mm.
emergency room. Somebody banged on the door and she had been treated from vehicle to vehicle for people to transport in because they were worried that they were going to get in trouble.
Right.
And and we gave this young lady multiple doses of naloxone, and we're having difficulty reversing her.
Mm.
And whenever she woke up, finally after like 4 or 5 doses of naloxone that we were giving her in an emergency department, right? So we knew how to administer the drugs. We had all the care and support available to her in our trauma bed. And she woke up and was very upset. And when we talked to her about, hey, here's what's going on, here's where you are. This young lady didn't even think that she had done any opioid. She was very upset about the fact that how would we even accuse her of something like that in our discussions. And I think that was uh, one of the cases that really made me understand like how many people are being poisoned by fentanyl
Yeah.
and have no idea what they are really coming in contact with. Um,
What did she think she took?
She thought
Or
that she was doing some methamphetamines and then taking some benzodiazepines, some Xanax
okay.
with that,
So,
and had done, had admitted to doing some illicit substances, or misusing drugs that were not
sure.
hers, but thought that, she was doing, an upper, and then she was going to take something, kind of take the edge off, and had no idea that she had taken fentanyl, and um, and trying to explain that and understand that for somebody who really believes that that isn't what they did. It's hard for them to perceive that. And, lucky for her to the extent that despite it should have been an EMS call, a 911 call,
Yeah.
that there was still people willing to bring her in, and that we as providers kept giving that naloxone, kept giving that naloxone, kept giving that naloxone until we were successful. Because if she had not made it there with that many doses,
It's a lot of fentanyl in your system. That's, you know.
right. And so it was eye-opening, for the community. And the fact of the matter was, it wasn't. I worked the next night in that same ER, and I had another gentleman that came in who had some length of sobriety and recovery, and came into contact with a family member that was still in their use, and had a new 9-month-old child, um, and he died. He didn't make it there in time.
The
And
child
so,
didn't?
no, the
Oh,
patient, the
the patient.
patient,
Okay.
yeah, the
Mhm.
patient didn't. But just the realization of
Yeah.
how just one more use can cause death, how fragile it all is, and really the amount of widespread use, even when a community doesn't think there is, that's so often, and a lot of that was miscalculated, even as far as death rates. A lot of cases during COVID got blamed on COVID that we know for a fact were overdose cases. That we were told by coroners that, due to families not wanting that to be the stigma related, that they were designated as COVID cases whenever, yeah, that they were designated as COVID cases. And so, um, yeah,
Which, yeah, it
it's
makes
a
it
shame.
harder to report on, and more people don't know it's out there when it's not reported properly.
Correct. And there's other individuals that I have a guy that's still in our practice today, that comes for care, that's one of our patients at River Valley Medical Wellness, that I walked by one day in the hallway, and he was actually been seen by one of my other providers regularly, and he stopped me and he said, "Hey, how you doing?" And I said hi to him, and he said, "You don't recognize me, do you?" And he was somebody that literally earlier in my ER practice we had reversed with naloxone multiple times. That now is successful in his recovery, and has a professional career. And he said, "Thank you for not giving up on me. Thank you for not judging me. You kept telling me, to keep having hope, and to work a program, and don't give up before the miracle happens." And so those are the cases that keep you going.
Yeah, it's beautiful.
They keep you going, and knowing that his family's intact, he's back working, he has a successful life, that he made it thanks to the fact that we had naloxone and he got in there in time. So
So have you had experience with overdoses from vaping?
I have, actually. It's really terrifying. So working in one of the more rural emergency rooms, I had a shift that I was on where we had 3 different overdoses that came in one day,
Mm.
um, that were all related to vaping. And I think for so many, again, it was one of these things where not the people who had the overdose were unintentional, for a couple of them, because one of them was at a family event, and the kids had gone out back, and somebody borrowed somebody else's vape, um, and didn't know that it had any fentanyl in it. And another person was sitting and watching a Razorback game with some other friends, and literally keeled over, smashed through a table, and people were unsure what had happened. He was a young guy, perfectly healthy. Like, why did something like that happen? And I think that that's one of the things that people don't realize is that the poisoning and contaminants that go into so many of these things, and another reason why it's so important as far as knowing what gets brought in, and that so many of these products are made and brought in from China and Mexico, and contaminating our supplies. Um, you may have the most innocent of intentions, but it does not mean that you will not be a victim. And when the first event happened that day, it was kind of a, well, that's odd, you know. But then you have three of them in a community, and then we started back tracing, and we could figure out that it came through a particular vape shop. However, that had happened, whether it was something that they had, or people knew that they could use this particular device to fill it and have fentanyl in it. It was terrifying. I mean, how prevalent is in vaping, and people thinking that it's not as harmful as smoking or things, but not always knowing what you are ingesting.
It doesn't seem like it's as regulated as maybe it should be. Or I've even heard stories from a doctor in California where they have, you can buy pot through a dispensary,
Mhm.
marijuana. Well, he said that there are just unlicensed dispensary shops popping up and the state can't keep up with them.
Right.
It will take months to get them shut down. And a pop-up shop like that is, I mean, my gut feeling is it's most likely there. It's just another way of illegally selling drugs that aren't licensed. So you don't know what
Sure.
you're getting.
Sure.
This is really, I think, doing this project for me in the last year, being, I don't know what generation I'm in, but I can't remember. Looking back at my podcast producer, you might know. I'm a millennial. Okay, thank you. Uh, I was never raised in a household that would ever condone doing illicit drugs, but marijuana has become very accepted culturally and legal in some places, and now we have, policymakers and politicians saying, "Oh, sure, legalize it." But I think, and maybe if you're going to a legal dispensary where you know what you're getting, but how do you know now?
So
How
you
do
really,
you know?
no, that's a great
And when you're
question.
17 thinking it's legal, you just might take whatever is, available to you thinking, well, this is society says this, culture says this. I think it's fed into this, the opioid epidemic. It's fed into this.
Those are great points. And I think that one of the things that people don't realize about vaping and the concentration of substances, whether
Mm-hmm.
it's cannabis, whether it's fentanyl, whether it's methamphetamine, any kind of substance, that whenever you put it into a device and you heat it up
Mm.
significantly, what you are doing is increasing the concentration. You
Oh, wow.
increase that concentration of how it's taken into the body. And so with like marijuana and things like that, there's already this increased concentration of THC in psychoactive substances. When you put it into a vape or a dab or something like that, where you heat it up, then your concentration is so much more significant. And I tell people this, like, marijuana today ain't the same as the 60s, 70s, and even 80s,
Mm-mm.
right? And it's because of not only the horticulturing and the growing of higher concentrations, but it's also the delivery systems that people
Interesting.
are using to do that. And so that makes it even more concerning, because we really don't know where. And I can't even believe that I'm really saying this, but to the extent of when you buy a medicine that's FDA approved, you know exactly what concentration you're getting,
Mm-hmm.
right?
Right.
Within a certain percentage that it has to do that in order to meet FDA standards. So if I'm getting a 10 milligram lisinopril, I know that I'm getting about 10 milligrams of lisinopril.
Yeah.
Um, but even whenever you are going to, whether it's dispensaries, um, as far as what the percentages are, but then the way that you use them, if you heat them up in a certain way, or you put it
Mm.
into a vape, then you are increasing the concentration so much that really it's misleading. You add some substances like fentanyl to that mix, then I mean, yeah, there's just not a way for people to be able to even judge what they're ingesting in any form because it's so difficult to tell that it's greatly increased.
No, I don't. The general public does not know that.
No, they don't.
They don't.
They don't, and a lot of they say a lot of people who are actively using don't know, except that they are looking for that increased, um, high or euphoria. But even if people are supposed to be trying to be careful, when you don't know what concentration you're really doing, then there's not a way to judge that. So
Exactly. Scary stuff. So let's go back to the naloxone you
yeah,
distribute. The organization I advise, Harbor Path, has partnered with you and naloxone. Are you just using the nasal spray, or are you also using higher doses of naloxone in your
we are
clinic?
using the higher dose of the Zimhigh 5 milligrams. We do have the 4 milligram
Mhm.
nasal spray, but we found in having both available for people, um, we have found that people have been thrilled and very interested in the Zimhigh 5 milligram. That's the auto injector.
Right.
And people want to know what that is. And they say, oh,
Yeah.
that's injectable. It's like an EpiPen, right? An epinephrine pen that
Mhm.
somebody might use if you had an allergic reaction. Um, by having that, we know that we're able to give a higher concentration immediately into the body that's injected like into the muscle. And it can be given through clothes. It can be given in a leg, in an arm. It can be given in different areas where sometimes when people have overdosed, finding easy access, trying to get somebody turned over to give a nasal spray isn't as easy. So we've actually had a lot of law enforcement that have utilized it. That said they really like being able to have the auto injector, that it's easier to administer. Besides the fact that they're getting the entire dose and that it's a higher milligram dose, because as you and I were talking before, um, very rarely do I give one dose of naloxone to somebody to reverse them. The concentrations of fentanyl are too high or often mixed with other substances. And so being able to have the maximum amount of dose that we can administer as quickly as possible is so important to that person's life.
So you've revived people on several doses of Zimhigh then?
Zimhigh, I haven't had to use
Yeah.
multiple doses of.
Oh,
I have with
wow.
the
So you're
I
saying
have with
what?
the nasal
Uh,
spray. I have with the nasal spray, and even as I say, our rural EMS
yeah.
crews, that we had provided them with that, were thrilled because they felt like that it gave them, um, just like somebody who needs addiction medicine care, it
Yeah.
might be 40 miles away. It's the same thing for an EMS crew. They may be 40 miles away from the closest hospital.
Mm.
So being able to administer something that's a higher milligram helps them because they have a lack of resources. They may only have a couple doses on their units, and if there's more than one overdose or an overdose that's got to go a longer distance in order to receive, definitive medical care, then they want those higher doses in a formulation that they can give easily in order to give their patient the best chance.
You're making me think we only keep a box of Narcan in each car, but maybe we need 2 boxes in the glove box. Um, Speaking of which, I'm so glad you're giving it away. I'm going to show you this. So this is a Teva brand. I went to my, oh, where do you want it, Matt? Sorry. Podcast producer Matt is directing me. I'm showing everybody this. And I'm showing them this because I went, before we saw each other at that conference, I went to CVS Pharmacy looking for more naloxone, and this is all they had. Do you have any guess on what the cost was? I don't know if I told you.
Well,
What you could guess.
I actually in my state we had actually researched it because we were concerned when it became an over-the-counter
Yeah.
medication whether insurances would still pay for it or what the cost would be. So it was like $46.35, but I don't know what it is
You
today.
got
That
a
was several
deal.
months ago.
You got a deal. This was $77 a box, and it took them about 7 minutes to find it behind the counter at the pharmacy. Then checking me out was like, do we run it through insurance? Is it easier not to? It took another 15 minutes. And I was thinking to myself, who is going to go to a pharmacy, stand around for at least 20 minutes while they look for naloxone, if they have it, and then pay $77 a box for it?
Correct. Well, I'm glad you brought that up because it's part of the reason why we have really tried to push naloxone for people to have it on hand. I tell
Yes.
people, you cannot save what you do not have in your hands, right?
Amen.
Like you point out, if you come onto an overdose, either in your home, in your community, at a place of work, in the parking lot at Walmart, you cannot use a medicine you don't have on hand. And so it's really important as far as having that availability. Um, so I think every home in America ought to have one, right? Because it may not be about you and your family, but it may be about your neighbor or somebody
Mhm.
that's nearby. Um, and we particularly find that for more rural environments, at least, that pharmacies aren't open on the weekends.
Right.
After Friday at 5 or 6, they're not open. So if most of the opioid overdoses are occurring on a weekend, they're occurring after a paycheck, they're occurring when people are out
Yep.
doing different
Friday.
things.
Yep.
Yep.
Thursday,
And
Fridays.
so if you don't have accessibility to it because you don't have a pharmacy that carries it, then that's a real problem. And so we really work to make sure um, that our emergency rooms, that there's different providers that have that accessibility. Um, I know that there's communities that have set up vending machines to be able to have it
Mhm.
available, and I think that's a great idea. People know where that is, because if you need it and you don't have it, then it's already too late. Just like what we were figuring out in the ER. By the time you get to me, the crisis has happened. We need to step out and make that available more easily. And I'm glad that they've made it as an over the counter medication. But again, the barrier sometimes to care. Not everybody has $77
Right.
to go and
Unbelievable.
purchase. You have to have some planning. There are states, like our state has made it to where you do not have to go see a doctor or get a prescription for it from a
Right.
physician. So that's great, that you can go to your local pharmacist. There's a statewide standing order, but not everybody has that. And so we need to do a better job of changing that for people across America.
I've even come across policy decision makers who want to save people, want to correct this problem, but don't even have Narcan in their possession or naloxone in their possession. So it's going to take, you bring up stigma a lot in drug use. I mean, there's nothing, why is there stigma with naloxone? I think there is.
There is, I think that I think people don't think it's going to happen to them, or they don't want to recognize it in their nearby setting.
Right in their
Uh,
community.
yeah, yeah, and there's so much that's not revealed about it. And I think, I mean, I've heard some stories about people traveling to the airport and somebody being in line in the TSA line that suddenly kind of crumpled over, and one of our state officials had naloxone on him and actually administered it. And
Wow.
they were like, wow, like, who would have thought that while you're standing in an airport that somebody would have that happen? And I remind people that not all opioid overdoses are related to fentanyl poisoning, right?
Mhm.
There's lots of
Sure.
different reasons. With a child, we have the saying, one pill can kill. Um, and we can have people whose medical conditions change. Maybe they've been on, consistent dosing. Um, Maybe they're a cancer patient who is starting to have some dehydration or kidney failure that's increased the concentrations, or somebody started a new medication that's kind of interacted with that. I want us to certainly recognize the fentanyl crisis, uh, but not everybody who has an overdose is using an illicit substance, and so we all need to acknowledge that and realize that, and that the people we're saving oftentimes are not even the person that had the substance. It's the person that comes into contact with that substance. And that's what our communities, our schools, our people working in state positions. A lot of the people asking us for naloxone are probation and parole, are
Mm-hmm.
um, our caseworkers going out into homes, are people working with different populations, state park rangers, um, different people that we may not always think about all the contacts that they have with the communities, but there's lots of contacts that they have that they want that help. They want to feel like that they're prepared with the tools that they need, just like anybody else.
Yeah, agreed. So we have a listener who sent me an email, and there's a question that I think that she posed to me for my guests. And maybe you can help, because what I like about River Valley Medical is I would say, whole health, or you try to address everything, not just like, okay, come in for this one thing, but go to somewhere else for your mental health needs. You try to provide them everything. So this listener's name is Tracy. She's like, I have a question that I can't begin to answer, but maybe you can with a guest on your show. The opioid epidemic and now the fentanyl epidemic seems like a multi-system, simultaneous failure of agencies and government. How do we correct this? What do you think of this thought? And her brother died 10 years ago of opioids. So
Okay. Well,
she,
I'm sorry for her loss.
same.
And I think that's a great question that we're all still trying to figure out the
Right.
answer to. But being somebody who works, I call it boots on the ground, right?
Mhm.
Community-based approach, working with organizations where we're looking at how do we change the systems, right? How do we make this work better with
Yes.
our hospitals, with our clinics, with our state organizations? And then, of course, I was in DC trying with the
Yeah.
American Society of Addiction Medicine, trying to talk to our senators and representatives and saying, here's ideas that we have that we think will help make change. I think, first of all, that we can't all work in silos,
Yeah.
that we have got to overcome stigma and
Mhm.
have some honest conversations about what's going on. Because I tell my patients all the time, like I can help to treat and to work with what I know is the truth, right? As far as
Mhm.
if we have honest problems, then we can find honest solutions. And so I think that there is a definite multifactorial problem going on. We have all the fentanyl that's coming into the country, and we know that that's got to stop, right? And I know that I have a senator from my state, Senator Tom Cotton, that's very big proponent of working on that. I think whenever we talk about the governments and the legislatures, making sure that we have funding that really goes out to programs that are providing evidence-based care and getting that money out to people who can help with the solutions as far as treatment options, recovery options. But I think the conversations also start in our households. We talk about dinner topics,
Mhm.
um, having honest conversations about what's going on, having those conversations in churches. We've had a lot of churches that have reached out to us to provide them naloxone. State
That's
conferences said, would you come and provide naloxone training to all of our people that are here for the state conference and provide them with free naloxone so they can take it back and have it at their churches. So everybody realizes that there is a problem. It's just, are they willing to step up and step across that aisle or to hold out their hand and to understand that? We personally take, as you say, a comprehensive approach in our clinics. And I think medically speaking, we do integrated healthcare, primary care, mental health, and addiction medicine all in one. People will not be able to reach all the resources they need necessarily for specialty, but it's going to require that um, more of the primary care providers become educated and agreeable to acknowledging and treating mental health and addiction issues in their programs and in their clinics. It's going to require more of the specialty physicians to coordinating with the ERs or primary care to acknowledge what's going on, and us working together instead of kicking the can down the road to the next guy or the next woman, because we will not get through this crisis um, fighting alone. We just won't. We've got to all really work together, and that takes honest conversations.
Well, any parting words for us, Dr. Martin?
Well, I appreciate the opportunity to talk with you. I know we are like-minded and sharing much the same passions. And I would just say, if you are a listener in a community or in a state that wonders how you can get involved, having these conversations is a great way to do it. Arming yourself with naloxone or with the understanding of the resources in your area that people can be referred to. There are some solutions. So my hope is that we will, as individuals and communities, and as a nation, that we will not give up before we find some solutions.
Thank you for coming on the show, Dr. Martin.
Thank you.